Good morning, students. Good morning, or good evening, or good afternoon, or maybe good night. Today we are having our last microbiology lecture. It is the last one. This lecture includes all the left viral agents that we should talk about. That's why it is the last one. You know that all lectures in virology are big, so it's also big, but this lecture includes the most important pathogens. Today we will talk about such pathogens as herpes viruses, prions and oncogenic viruses, hepatitis viral pathogens, and causative agents of acquired immunodeficiency syndrome, or HIV. The first group of viruses that we will talk about are herpes viruses. Characteristic of herpes viruses, antigens and its cultivation. Firstly, we should talk about its taxonomy, its Latin name. Herpes viruses belong to family Herpes virida, and there are three subfamilies. The first one is alpha herpes virina. This subfamily includes such genera as herpes simplex virus type 1 or HSV1, herpes simplex virus type 2, or its short name is HSV2, and Varicella Zoster virus. Varicella Zoster virus causes chickenpox disease and shingles. Herpes simplex virus is so-called oral herpes. Oral herpes. Herpes simplex virus 2 is genital herpes. I will explain it in pathogenesis. The second subfamily is beta herpes virina, and it includes such genera as cytomegalovirus or SMV, then human herpes virus type 6 and human herpes virus type 7. Both human herpes virus type 6 and type 7 cause such disease as roseola. And the last subfamily is gamma herpes virina. It includes genus Epstein-Barr virus (EBV) that cause such diseases as Infectious Mononucleosis and Burkitt lymphoma. This subfamily also includes such genus as human herpes virus type 8 that cause Kaposi sarcoma. It is a type of cancer that occurs in immunocompromised patients. Firstly, about structure of herpes viruses. Herpes viruses are spherical herpes. They have spherical virion. They have double-stranded DNA, and it is enveloped viruses. It has a capsid and envelope. Which antigens are present in herpes virus? The first one, these are glycoprotein spikes that are located on the surface of envelope, glycoprotein spikes. And the second one, it is proteins of tegument. What is it? Between the capsid and envelope there is a layer of proteins that is called tegument that contains viral proteins and enzymes for viral replication. It is shown in blue color. We can cultivate herpes viruses in tissue cultures, for example, HeLa. Epidemiology and pathogenesis of infections caused by herpes viruses. There are a lot of infections. Firstly, a lot of genus, a lot of genera, and a lot of infections caused by herpes viruses. But they are similar in source. Source of herpes viruses are sick man or carrier. Then I will tell you that in most herpes viral infections, the patient who is infected once is left a carrier for all the life. How are these infections transmitted? Firstly, for herpes simple virus type 1, it's contact transmission through infected lesions, oral to oral contact. Oral to oral contact, for example, in kissing. In herpes simple virus 2, it is contact but sexual contact. Sexual contact. In Varicella Zoster virus, it's contact, direct contact with infected lesions and airborne. Cytomegalovirus is transmitted through contact, direct contact, sexual contact, direct contact with objects contaminated with saliva or other human body fluids. Sexual contact, then from mother to fetus and through transfusions when blood components contain virus. Epstein-Barr virus is transmitted through contact, through kissing with saliva that contaminate other different objects, sharing of items such as toothbrushes and cups. So contact with objects that are contaminated with different human body fluids. Herpes virus, human herpes virus type 6 and 7 is transmitted through airborne transmission via respiratory droplets. I remind you it causes roseola. And human herpes virus type 8 that cause Kaposi sarcoma is transmitted through sexual contact, direct contact through saliva, or from mother to fetus. The first disease that is caused by herpes viruses is herpes simple virus type 1. I remind you it's transmitted through oral to oral contact in kissing, for example, or in sharing. It also may be in sharing of objects contaminated with virus, bottles or cups. Human herpes simple virus type 1 can set up a primary infection in the lips. You can see here. Then this virus moves to the trigeminal ganglion, from the lips to the trigeminal ganglion, where it can remain latent. After primary infection, herpes simple virus 1, the person becomes carriers. Virus is left in trigeminal ganglion for all the life. If person is infected once, it is latent for all the life. Then, after some time, virus can reactivate, move to the original site of infection, to the lips, from trigeminal ganglion, and result in cold sores. So, It doesn't mean that patient is infected once more. No, it's due to reactivation of virus. And virus move through peripheral nerves to the original site, to the lips, to the mouth. This source may occur in mouth, for example, in lips, next to the lips on the skin. Why is virus reactivated? Reactivation of virus is caused by physical or physiological stress, by different infection, fever, irradiation, by cold, for example. That's why you may notice that maybe your friends or your relatives have such clinical manifestations in the in winter, for example, especially during exams, because it's stress. What are clinical manifestations? Firstly, the only visible clinical manifestation that occurs in everyone, it is formation of vesicles or formation of sores in the lips, on the skin, or in the mouth. But some patients also have such clinical manifestations as fever, sore throat, pharyngeal edema, and erythema or redness. Erythema is redness, and vesicular or ulcerative lesions on the oral and pharyngeal mucosa. Such lesions occur in a mouth, on the mucosal membrane of pharynx or mouth. Recurrent herpes simple virus 1 infection of the oropharynx is herpes labialis. It is this one. Usually appear on the vermilion border of the lip. These lesions, this one and this one, these lesions contain fluid that is filled via large amount of herpes viruses. So in these vesicles, here and here in mouth, there are a lot of herpes viruses. That's why it is transmitted through kissing or through sharing of some objects, bottles or cups, when virus is left on the surface of these objects. Another one that also belong to family alpha herpes virina, it's herpes simple virus type 2 that causes genital herpes. So you understand it's transmitted by sexual contact, through sexual contact. Primary infection usually involves such organs as vulva, vagina, and cervix in women. So these lesions or sores occur in vulva, vagina, and cervix, or in men in the glans penis, prepuce, or penile shaft. Clinical manifestation includes fever, malaise, lymphadenopathy, dysuria, and urinary retention due to urethral involvement. So such vesicular lesions occur in sexual organs in different part of urogenital tract. Another virus that belongs to family alpha herpes virina is Varicella Zoster virus. Varicella Zoster virus causes two diseases. Primary infection is varicella or chickenpox. In most textbooks it is named chickenpox, in some books it's named varicella. And another one, it is a secondary infection, it is a zoster or shingles. What does it mean, primary or secondary infection? Chickenpox occurs in the children primarily in the childhood, and then in the adulthood any person who was infected via chickenpox in the childhood may develop shingles. What about chickenpox? Chickenpox or varicella is an initial infection or primary infection. The lesions are vesicles, eventually becoming pustules and rupture and form caps. The virus then moves to a dorsal root ganglion near the spine, where it remains latent indefinitely. Incubation period of chickenpox is from most common is from 14 up to 16 days. But we used to say that the largest the longest period for incubation of this virus is 21 days. If, for example, you are not sure that you or your children are infected via chickenpox, for example, we can imagine that the person has contacted with sick child, and we don't know this person is infected or not infected. We should wait for 21 days. If there will not be, if there are no any clinical symptoms during 21 days, during 3 weeks, means the patient is not infected. 21 days is the maximum incubation period for chickenpox. So how does it develop? How does chickenpox develop? Infection. Firstly, I have said that it's transmitted by contact with vesicles, these vesicles, or through airborne, because these vesicles are also present in mucosal membrane of mouth. Contamination of the child occurs due to virus containing droplets from upper respiratory mucosa. You can see in speaking or in coughing. Then virus colonize and replicate in upper respiratory tract and spreads to regional lymph nodes where it replicates. Regional lymph nodes. Then virus spreads to the liver and spleen from the blood. It is the stage of incubation period. Incubation period, we have said, it lasts from 14 up to 16 days up to here. Incubation period when there are no any clinical symptoms. It is impossible to know the child is infected or non-infected. Then the second one is contagious period that starts from in middle it's from 16th 17th day. We can see from here. It is a stage of secondary viremia when virus enters from internal organ to the blood once more, from internal organs where it replicates to the blood, and it causes infection of the skin that leads to appearance of vesicular rash. Virus enters the skin, so we can see rash, vesicular rash, or vesicles or lesions. These vesicles contain large amount of viruses that are present in fluid. They are fluid filled vesicles. This period is named contagious period because the child is infectious in this period. In incubation period, child can't infect another person. But in contagious period, the child is contagious. Is infectious means it may infect the person. Almost all doctors think and say that the child becomes infective or contagious 2 days before rashes. 2 days before rashes. So, for example, if rashes occur on the 22nd day of the disease, so on approximately on 18 or 20th day of the disease, the child is infective, becomes infective. So the child is infective even if we can't see vesicles on the skin. Vesicles may be in the mouth once more. And then after contagious period, there is a viral latency period, when virus enters cutaneous neurons and migrates to ganglia, where it enters a latent state. So I have said that virus is survived in dorsal root ganglion near the spine, where it remains latent for all the life. So anybody who was infected via Varicella Zoster virus has this virus in dorsal root ganglion. In these photos, you can see typical cases of chickenpox. We can see lesions. They may be seen in various stages, with some in the early stage of development and others in crust stage. What about reactivation? We have said about reactivation in herpes simplex virus 1 that it's also remain latent in trigeminal ganglion, and we have said about varicella zoster virus that is also latent, and in the adulthood it causes such disease as shingles. Shingles occur in late adulthood when the latent varicella zoster virus becomes reactivated, causing shingles. Shingles is characterized by formation of lesions along peripheral nerves, where virus reach the skin. Reactivation of virus can be caused by stress or weakening of the immune system. And I have said that we can see these vesicles. And these vesicles occur in groups that resemble belt, like belt. It is very painful. It's very painful. The patient is impossible to move or to turn the body. It's a very painful state. The another one, cytomegalovirus, that belongs to family beta herpes virina. Cytomegalovirus infects epithelial cells and leukocytes. Cytomegaloviruses are named for their tendency to produce giant cells with nuclear and cytoplasmic inclusions. Cyto means cells, megalo means large or big. So they produce giant cells with nuclear or cytoplasmic inclusions. Cytomegalovirus spread to all organs. Virus shed in body fluids many years without causing of any symptoms. So if it enters human organism at once, it is latent. It is served for all the life. It is latent in neutrophils, monocytes, salivary glands, tonsils, and kidneys. Cytomegalovirus is the most common in utero infection when it infects the child, the baby intrauterine, if mother is infected. So congenital cytomegalovirus infection occurs in 1% of all live births. Once more, most cases of cytomegalovirus are asymptomatic. Asymptomatic means they are without any clinical symptoms. Without any clinical symptoms. It is known that a lot of patients, a lot of people, about 90% of all people have antibodies to cytomegalovirus. It means that they were infected. About 80-90% of all people in the world have antibodies to cytomegalovirus. In the case of severe disease, severe symptomatic disease, cytomegaloviral infection is characterized by hepatosplenomegaly, myocarditis, optic atrophy, deafness, and pneumonia. The another one, it's Epstein-Barr virus. What about pathogenesis of this one? Epstein-Barr virus replicates in oral epithelia and tonsillar B cells. Virus promotes growth of B cells, so it becomes transformed, and T cells, CD killers, CD8 cells, T cells kill and limit B cell outgrowth. Epstein-Barr virus established latency in memory B cells, and Epstein-Barr virus is reactivated when the B cell is activated. When B cell is activated, when there is any other infection, because B cells are activated by T helpers to produce plasma cells for synthesis of antibodies. So target cells for Epstein-Barr virus are or epithelial cells and B cells that become transformed. Carriers of Epstein-Barr virus have virus for all the life. Symptomatic infection with Epstein-Barr virus leads to mononucleosis. So disease that is caused by Epstein-Barr virus is called infectious mononucleosis. Infectious mononucleosis is a disease marked by sore throat, high fever, and cervical lymphadenopathy occurring after a long incubation period. From 30 up to 50 days, about 2 months. Some patients also display gray-white exudate in the throat, skin rash, and enlarged spleen and liver. What is another disease that may be caused by Epstein-Barr virus? It is cancer. It is so-called Burkitt lymphoma. So cancer is a potential complication of Epstein-Barr virus infection with Burkitt lymphoma. It is B-cell cancer and nasopharyngeal carcinoma, or cancer of nasopharynx. So due to ability of Epstein-Barr virus transform B cells, it is the cause of B-cell cancer, Burkitt lymphoma. The another herpes viruses are human herpes virus type 6, 7, and 8. The first one, human herpes viruses type 6 and 7, are transmitted by airborne transmission through respiratory droplets and cause such disease as roseola or exanthem subitum. It is characterized by fever during 3-5 days, followed by lacy body rash. Lacy body rash. If you don't know what is lacy, it resembles lacy. So translator, look for what is it. It is characteristic, lacy body rash is characteristic of roseola. Human herpes virus type 8 cause such disease as a Kaposi sarcoma. That's why it is named. It's also named Kaposi sarcoma associated herpes virus, or KSHV. Is transmitted by sexual contact, direct contact, contaminated saliva, or from mother to fetus. Kaposi sarcoma is a type of cancer of the skin. You may see brown and dark spots or malignant formation on the skin. In mouth, cancer of the mouth, and sometimes internal organs. Microbiological diagnosis, treatment, and prophylaxis of herpes viral infections. What is specimen? It's respiratory. It includes respiratory samples, tissue and body fluids, saliva, for example, nasopharyngeal swab, smears of skin scrapings in chickenpox, in or oral herpes, or scrapings of urogenital system in genital herpes, swabs of the base of vesicles, blood and serum. Which methods are used for diagnosis? The first one, it's direct detection in skin lesions. It is a preparation of zinc smear. What is it? It's scrapings of the skin, preparation of smear, staining by Hbs stain, and we can see multinucleated giant cells with nuclear inclusions. This is a human skin cell that contain a lot of that are giant and a lot of some nucleuses and inclusions. And immunofluorescence test is used for direct detection of the virus in skin lesions. Then PCR is used for detection of the virus. Cultivation of virus, that includes virus isolation on cell culture. And serological tests, immunofluorescence test, complement fixation test, and ELISA. Serological tests are especially important for detection of IgG and IgM, IgG in past infection in cytomegalovirus and Epstein-Barr virus, because sometimes when patient has a long fever, enlarged lymph nodes during long period, doctor advised to detect antibodies to cytomegalovirus or Epstein-Barr virus. Prophylaxis. For herpes simple virus, firstly, virus is carried in latent state in the presence of antibodies. Reinfection may occur, so there is no immunity. Patient is susceptible to this infection. Patient may develop clinical manifestations a lot of time during all the life. It depends on the factors that activate this virus. Vaccine against herpes simple virus type 1 and type 2 are not available. The another is Varicella Zoster, that causes chickenpox and shingles. Previous infection with varicella is believed to confer lifelong immunity to at least about 20 years. But shingles occurs in the presence of virus in host. So shingles occurs only in the patient who was infected in the childhood. Today there is a vaccine to prevent chickenpox. It's a live attenuated varicella vaccine, and there is a herpes zoster shingles vaccine that is recommended for patients with chronic medical conditions and for persons older than 60 years of age, because in this age patients are most susceptible to develop shingles. Cytomegalo virus. Its reactivation of latent infection occurs in the presence of antibodies. So there are no any vaccines. There is no immunity. In herpes simplex, in human herpes virus type 6, 7, and 8, vaccines are also not available. What about treatment? There are specific antiviral drugs that are used for inhibition of replication of herpes viruses. They include acyclovir, valacyclovir, famciclovir, and ganciclovir. They inhibit replication of viruses. They may be in form of tablets or in form of ointment that may be placed on the lips, for example. So these drugs inhibit viral replication and stop the infection. Once more, they may be used in the form of tablets or ointment, for example, for treatment of herpes simplex simple virus type 1 and type 2. Another group of diseases that we should discuss today are hepatitis. Firstly, what is hepatitis? Hepatitis is an inflammation of the liver. Human hepatitis is caused by at least 6 genetically and structurally distinct viruses. So, one disease, that is hepatitis, infection of the liver, is caused by different viruses. The diseases caused by each of these viruses are distinguished in part by the length of their incubation periods and the epidemiology of the infection or transmission ways. So, all hepatitis that we study may be divided, may be classified into two groups. These are food and waterborne hepatitis and blood-borne hepatitis. Food and waterborne hepatitis includes hepatitis A and hepatitis E that cause only acute infections. In hepatitis A and E, there is no chronic infection. And these hepatitis are transmitted through food, infected food or water, through direct contact. Hepatitis B, C, and D are blood-borne. They are transmitted through blood contact, through sexual contact, through contaminated blood or medical instruments. They cause both acute and chronic forms of hepatitis. So let's talk about the first one, hepatitis A. This virus that causes hepatitis A belongs to family Picornaviridae. I remind you that another virus that belongs to this family is poliovirus that causes polio. Family Picornaviridae, genera Hepatovirus. It is a causative agent of hepatitis A. By the way, from the name of the family, you may understand that this is RNA viruses. Pico means these viruses were discovered, were isolated by Italian scientists, Italian doctors from Italy. And that's why it's translated from Italian language. Pico means tiny or very small, because it is one of the smallest virus, and RNA means they contain RNA. First, let's look at this map, and find out which countries are the most susceptible to hepatitis A. So hepatitis A is prevalent in countries with warm, wet climate, with countries with poor hygiene, in countries where water for cooking or for drinking is taken for is not sterilized, not disinfected. These are all African countries. These are all countries of South America: Argentina, Brazil, Chile, Peru, Mexico. These are all Asian countries, Eastern Asia or Western Asia. So, high prevalence of hepatitis A is observed in countries where hygiene is poor and with a warm, wet climate, when virus may replicate and may be served. Hepatitis A virus is a small virus. It's naked virus. It doesn't have envelope. It contains RNA positive chain. This virus have S antigen, soluble antigen, so called soluble antigen. That is a combination of nucleic acid and capsid. It's very simple virus. It may be cultivated in the primate cell lines, monkey cell lines. Epidemiology and pathogenesis of hepatitis A. Source of infection are sick men. Transmission, we have said it's foodborne and waterborne hepatitis form. It's transmitted by the fecal-oral route, by ingestion of contaminated food and water, and by direct contact. It never causes chronic liver disease. Never causes chronic liver disease, only acute infection. Immunity after hepatitis A is lifelong. There are two clinical forms of hepatitis A. These are asymptomatic infection, asymptomatic disease, or anicteric. Icteric means yellowish of skin and eyes. Asymptomatic or anicteric means without symptoms, without yellowish of skin. It occurs in 90% of cases. And another one is symptomatic or icteric disease with symptoms with yellowish of skin. It occurs in 10% of cases. How disease develops? Hepatitis A virus enters the body by ingestion of food or water. Then it spreads by the bloodstream, crosses intestine, enters the bloodstream. Then from the blood it enters the liver. That is a target organ for hepatitis A virus. In liver, hepatitis A virus causes cell necrosis, and it results in enlargement of the liver, hepatomegaly, enlargement of liver. This virus frequently causes blockage of the biliary excretions when bile is not released, resulting in jaundice, dark urine, and clay-colored stool. Jaundice, dark urine, and clay-colored stool are visible clinical symptoms of hepatitis A if it is symptomatic or icteric form. And then virus enters the stool, enters the feces. In these photos, you can see main clinical manifestations. Due to presence of bile in the blood, it's dark urine, jaundice, and clay-colored stool. These symptoms are visible in icteric form of hepatitis A or in symptomatic, that that is about 10% of all cases. Hepatitis A is considered as a mild infection. There is no chronic infection. Why? Because it is naked virus, and it doesn't integrate its genome to human hepatocytes. That's why there is no chronic infection. All infected cells, all infected hepatocytes are destroyed, and then liver remain normal. You know that liver is the organ that may restore after some time. So if there are no infected cells, it becomes normal. Hepatocytes, normal hepatocytes multiply, and the patient becomes healthy. Unlike in hepatitis B, I will explain that in most cases it is chronic, and I will explain why. So, due to viral cycle, due to replication of the virus, it is naked virus, so it is never present inside hepatocytes. It destroys hepatocytes and released from hepatocytes, and then released with feces. Due to it, there is no chronic hepatitis A, only acute infection. For diagnosis, we can collect such specimen as stool, blood, and serum. Stool firstly, feces. Methods that are used, it's PCR, polymerase chain reaction, direct detection of virus by ELISA, when we can detect antigen in stool. Then there is a method for detection of liver function tests. When we detect the presence or absence of some enzymes, liver enzymes. For example, serum and urinary bilirubin increases, alanine aminotransferase (ALT) increases, aspartate aminotransferases increases, gamma glutamyl transpeptidase (GGT) also increases. So these liver function tests are increases in hepatitis. Serological tests are used for detection of anti-hepatitis A/V antibodies. In acute infection, IgM is detected. You remember that IgM is detected in acute infection. In past infection, when the patient has immunity or patient was vaccinated earlier, we can detect IgG. We may use ELISA for detection of these antibodies. What about prophylaxis? Prophylaxis of hepatitis A includes using of vaccine. I have said that immunity is lifelong after hepatitis A. For prophylaxis, we can use formalin inactivated hepatitis A vaccine, Havrix, it is called Havrix. Or another one is a Twinrix, that is dye vaccine. It is used for protection against both hepatitis A and B. The first one, Havrix, may be used for the children from 1 year, from 1 year. What about general prophylaxis? Proper sanitation must be used to prevent fecal contamination of water and food. Hepatitis E virus is transmitted through especially drinking water that is used from rivers or from other sources when human feces, enters these rivers or lakes or ponds. There are no antiviral drugs for treatment of hepatitis A. Another one is hepatitis B. Hepatitis B virus belongs to family Hepadnavirida. Hepa means target cells for this virus. DNA is hidden here in the name of family. It means that this is DNA containing virus, and it belongs to family to genus Orthohepatnavirus. What about spreading of hepatitis B? Hepatitis B, actually, this virus, this disease is present in all countries in a different amount. We know that it's present in high amount in countries where population is larger, when territory is small but population is large. Structure of hepatitis B virion. This is small enveloped DNA virus. It contains DNA. Small circular, partly double-stranded DNA. Hepatitis B virus may be in the following forms: DNA particle, it is infectious form, filamentous particle and spherical particle that are non-infectious form. We can see in this diagram it is DNA. Then we can see some antigens of this virus. It's core protein HBC. HBC means hepatitis B core. Is present in the capsid. Then surface protein antigen, that is HBS surface. HBE is also present in envelope. They play a great role in pathogenesis and diagnosis of hepatitis B. I will tell you about it. So once more about antigens. Surface antigen, HBS antigen. Hepatitis B surface. You may memorize it like this one. HBS antigen, let's look for this one. It's produced in excess by the infected hepatocytes. So it's present in acute infection. Double-stranded circular DNA and polymerase enzyme surrounded by the core antigen, HBC antigen, core antigen here. It's shown in green color, HBC antigen. HBE antigen is the soluble component of the core, which is released during active infection. It is not shown here, but memorize that it is produced. It is a component of core here in acute infection. HBX antigen is a transactivator of viral transcription that appears to contribute to hepatitis C cancer. It plays a great role in cancer of liver. So about particles, it is a DNA particle that has all antigens, that is infectious particle. If it enters, it may infect hepatocytes and cause infection. Filamentous particle and spherical particle, you can see that they have no these antigens, they are non-infectious. Cultivation of hepatitis B virus is not available, is not used. Epidemiology and pathogenesis of hepatitis B. Source of infection is sick man. It's transmitted by sexual contact, parenteral transmission through needle stick injury if it is infected, and from mother to fetus. Chronic hepatitis B occurs in from 10% up to 15% of adult patients, and from 30 up to 90% of young patients. Hepatitis B is causally associated with primary hepatocellular carcinoma and cirrhosis or destruction of liver. Who is the greatest risk for hepatitis B infection? The first one, these are drug abusers because they share the same needle stick, for example, syringes. Blood product recipients, about for 5–10% post-transfusion hepatitis occurs due to contamination after transfusion of blood or blood components. Hemodialysis patients. Dialysis, it's process of filtration of the blood in the patients who have problems with kidneys. So it's so-called artificial kidney. The artificial kidney is used to filter and make filter blood from wastes and metabolites. After, if this device is infected, it's also may cause hepatitis B. Lab personnel, lab workers who work with blood products, sexually active homosexuals, persons with multiple and frequent sex contacts, medical and dental personnel. So everyone who potentially contacts with blood or blood components, or with sexually active persons, because hepatitis B virus is present in large amount in genital excretions. Pathogenesis of hepatitis B. Virus enters into the bloodstream, then it replicates in the liver within 3 days. Symptoms may not be observed for up to 45 days or even longer. Hepatitis B virus genome integrates into the hepatocyte's chromatin and remain latent. So it is very important. It is a very important stage of pathogenesis when hepatitis B virus integrates its genome, its DNA, into human hepatocytes genome, into human genome, human DNA, and in this stage infection becomes latent. Then virus replicates in hepatocytes with minimal cytopathic effects. But every hepatocyte that multiply during infection is infected, because this hepatocyte genome contain viral DNA. When human hepatocyte multiply into 2 cells, divide into 2 cells, every new formed 2 cells, new multiplied 2 cells, also contain viral genome. Then these 2 cells multiply once more, and they also new format new cells, hepatocytes, also contain viral genome. Infection hepatitis B persists for a relatively long time without causing liver damage. For example, elevation of liver enzymes level or symptoms. Hepatitis B virus can cause acute or chronic, symptomatic or asymptomatic disease. This disease is characterized by a long incubation period, ranging from 6 weeks up to 6 months. The clinical manifestations vary from subclinical hepatitis, I've said about it, to symptomatic and icteric hepatitis. Mild cases that don't result in jaundice are termed anicteric. I also said about it. Clinical manifestations of hepatitis B virus infection depend on age of infection, immune status of the host, and level of hepatitis B virus, amount of hepatitis B virus. Microbiological diagnosis of hepatitis B virus. Specimen includes collection of blood, because the hepatitis B virus is present in the blood in large amount. Semen or vaginal discharge, because it's also released. It's also present there in large amount. Human body fluids. Breast milk also contain hepatitis B. Methods that are used for detection of hepatitis B virus. It's the first one, PCR. The second one, detection of antigens, Hbs antigens, Hbe antigens that are present in acute infection. Then biochemical tests of liver tests function that detect increased level of liver enzymes such as alanine aminotransferase, bilirubin, and others. Serological tests, it's detection of antibodies to Hb antigen, antibodies to HBC, IgM, it's detect acute infection, antibodies against HBC, IgG antibodies, and antibodies against Hb antigen. It's detected by radioimmunoassay or ELISA. I have said to you about main antigens in hepatitis B, and they are used as main laboratory markers for detection of infection and their interpretation. So we can prognose the disease stage of disease, hepatitis B, by using of these markers. The first one is Hbs antigen. It's surface antigen. I remind you, surface protein that is present in acute or chronic infection. It is detectable in the blood from 1 to 6 months after infection. Antibodies to Hbs antigen, anti-Hbs, it's antibodies to Hbs antigen, is a marker of recovery and or immunity to hepatitis B infection. They are present, they occur from about 8 months after infection. So they may be detected in convalescent patient who recovers after infection. Antibodies, IgM, anti-HBC IgM. These are IgM antibodies against HBC antigen. It's marker of recent acute infection, less than 6 months, because IgM is produced in acute infection. HBC antigen is present in also present in acute infection. Anti-HBC IgG, so antibodies to IgG antibodies to HBC antigen. It is detected in past or chronic infection. Hbe antigen indicates active replication of virus and therefore infectiveness. It is detected from 2 up to 6 months after infection. So, for example, detection of IgM anti-HBC and Hbe antigen detects acute infection, recent infection. Anti-Hbe or antibodies against Hbe means that virus no longer replicating, and detection of DNA indicates active replication of the virus. What about treatment and prophylaxis of hepatitis B? We may use antiviral drugs for treatment of hepatitis B. These are such drugs as lamivudine, adefovir, entecavir. Injection of anti-HBV immunoglobulin and interferon also showed their effectiveness. Immunoglobulin against hepatitis B virus and interferon is non-specific protein cytokine, interferon alpha, that inhibits viral replication. Prophylaxis. Hepatitis B is a so widespread disease in all the countries. That's why today we use necessary or obligatory prophylaxis in any country. In all countries all the world, we must vaccinate the person. And vaccination of vaccination against hepatitis B is made in the newborn during the first day after birth. We may use monovaccine that are that contain Hbs antigen like Antigens B or Recombivax B, or dye vaccines like Twinrix. It's inactivated hepatitis A virus vaccine and in combination with Hbs antigen. All vaccines against all monovaccines and dye vaccines that contain Hbs antigen are recombinant antigen vaccines. I talked about it in immunology, about recombinant vaccines. In hepatitis B, great role in pathogenesis belong to Hbs antigen, so we don't need whole viral particle for this vaccine. We need just Hbs antigen. How to isolate this protein? We should isolate gene that is responsible for expression of Hbs antigen. This gene is inserted into plasmid of yeast. Plasmid, you remember, it's circular DNA, and then it's inserted to yeast. Yeasts are microorganisms that these are fungal cells. That are not harmful. And when a yeast cell gets new gene with plasmids, it produces Hbs antigen. So Antigens B, for example, this vaccine contains only Hbs antigen. There is no one living viral particle, only Hbs antigen. Once more, this vaccine is given for any newborn in any country of our world. Hepatitis C is the next one. Hepatitis C. It belongs to family Flaviviridae and genus Herpes Virus. Flaviviridae, we talked about this family last lecture. I will ask you which other viruses belong to this family. So repeat, please. Hepatitis C virus is a global health problem for all the world. There are a lot of patients and carriers who live with hepatitis C during all their life. So it's widespread. It is widespread in all the countries. Hepatitis C virus is RNA positive virus. It contains RNA positive chain. It is spherical, and it is enveloped virus. Enveloped virus, it has capsid and envelope. It has core antigen. You can see here in capsid. The viral RNA polymerase is error prone and generates mutation in the glycoprotein and other genes. It is very important to memorize because it generates antigenic variability. Such variability makes the development of a vaccine very difficult, and it is impossible. Today there is no vaccine to prevent hepatitis C due to its high mutation of RNA polymerase that arises in different antigenic variations. Epidemiology and pathogenesis of hepatitis C. About 85–90% of patients develop chronic hepatitis C infection. The source of infection are sick human. There are no carriers here. Transmission is a parenteral transmission through sharing of drug injection equipment, syringes or needles, or from transfusion of unscreened blood or untreated clotting factors. The second transmission way is sexual transmission, and the third one is from mother to fetus. So, transmission of hepatitis B and hepatitis C is similar. They have similar transmission ways, but it is known that infective dose of hepatitis C is bigger than in hepatitis B. Contagious period extends from 2 up to 3 weeks before and 10 weeks after onset of symptoms. Contagious period means when the patient is infective for other persons. Who are the great risk patients for hepatitis C infection? These are also drug abusers, blood product recipients, hemodialysis patients, lab personnel working with blood products, sexually active homosexuals, persons with multiple and frequent sexual contacts, medical and dental personnel. The same like in hepatitis B. What about pathogenesis of hepatitis C? The ability of hepatitis C virus to remain cell-associated and prevent host cell death promotes persistent infection, but results in liver disease later in life. Cell-mediated immune response are responsible for both the decreasing of infection and tissue damage. Antibodies to hepatitis C virus is not protective. About 65% of infected individuals have no symptoms relating to the acute infection, while only about 25% have jaundice. Jaundice occurs due to the same reasons, due to the same causes like in hepatitis A or B, due to destruction of liver, disruption of liver cells, and increasing of bilirubin in the blood. Hepatitis C virus. Hepatitis C is so-called mild killer because most patients don't have any symptoms, but the result is terrible. The result is in cancer, liver cancer, or cirrhosis. So, there are some types of hepatitis C. I have started to talk about it. About 50% of patients after acute infection recover. About 15% have cirrhosis, rapid development of cirrhosis, and about 70% of patients have persistent infection. Persistent infection may be asymptomatic, and persistent infection may lead to chronic hepatitis. Chronic hepatitis that is characterized by liver failure, cirrhosis, disruption of liver, and hepatocellular carcinoma. Microbiological diagnosis, treatment, and prophylaxis of hepatitis C. Specimen includes collection of blood, semen, and vaginal secretions. Biochemical tests are also used for detection of hepatitis C, detection of the level of bilirubin and enzymes, ALT and AST, alanine aminotransferase, for example, aspirin aminotransferase. Serological tests are used to detect antibodies and antigens like ELISA and polymerase chain reaction. What about treatment and prophylaxis of hepatitis C? There is no vaccine for hepatitis C, although several candidate vaccines are undergoing tests. I have said why today there are no vaccines. For treatment of hepatitis C, we may use alpha interferon and ribavirin. Ribavirin is used for all flaviviruses. Hepatitis D or Delta virus. A family is not unclassified. It's not named. Genus Delta virus. This virus is responsible for causing about 40% of fulminant hepatitis infections. Hepatitis D virus causes infection only in the presence of hepatitis B virus. Genome of this hepatitis D is single-stranded RNA negative chain. Antigens are delta antigen. This is detectable in early acute hepatitis D infection. Delta antigen you can see in this diagram, is the only protein coded by hepatitis D virus RNA. Hepatitis D virus uses hepatitis B virus and target cell proteins to replicate and produce its one protein. So we can't see what is shape of this virus because hepatitis D virus is only nucleic acid RNA negative, and delta antigen, this one that is produced in the presence of hepatitis B. Hbs antigen is essential for packaging the virus and transmission. So Hbs antigen, it's antigen of hepatitis B. Hepatitis D virus may be replicated only in the presence of hepatitis B because it must integrate its genome to hepatitis B virion and replicate delta antigen and its envelope by the presence of hepatitis B. Cultivation of this virus is not available. Microbiological diagnosis, epidemiology and pathogenesis, then microbiological diagnosis, treatment and prophylaxis of hepatitis D virus. It's transmitted in blood transfusion. It's the most common. And through sexual transmission. It is rare. It's mostly transmitted through blood transfusion. Incubation period includes from 21 up to 45 days. It can replicate and cause disease only in people with active hepatitis B infection. I've said that hepatitis D virus needs hepatitis B to replicate because hepatitis D is only nucleic acid. A person can be co-infected with hepatitis B virus and the delta agent. A person with chronic hepatitis B virus can also be superinfected with the delta agent. Co-infected when hepatitis B and hepatitis D infect the person at one time. Super infected means when firstly person is infected with hepatitis B and after that it's infected by hepatitis D. Replication of the delta agent results in cytotoxicity and liver damage. For example, we can imagine that person with hepatitis B is asymptomatic. He or she has chronic infection, and he is recovery, but if hepatitis D is transmitted, enters the human organism of this patient with hepatitis B with mild infection, for example, it causes liver damage, and it causes a so-called fulminant hepatitis. Fulminant hepatitis is a very severe form of hepatitis that causes altered brain function. It is hepatic encephalopathy, extensive jaundice, and massive hepatic necrosis, which is fatal in 80% of cases. Patient with hepatitis B may live long in the life, but patient who is co-infected or superinfected with hepatitis D after hepatitis B die in most cases, almost any patient. Microbiological diagnosis of hepatitis D. Firstly, for diagnosis, we should collect blood. Diagnosis methods are similar to hepatitis B. What about treatment and prophylaxis? We have said that hepatitis D may occur in the patients with hepatitis only with hepatitis B, so delta hepatitis can be prevented by vaccination of hepatitis B virus susceptible persons with hepatitis B vaccine. If person is vaccinated against hepatitis B, this patient is not infected, never can be infected with hepatitis D. Another hepatitis virus is hepatitis E. Hepatitis E belongs to family Caliciviridae. Genus is not unnamed, is not classified. Hepatitis E is also foodborne and waterborne hepatitis virus. It is present in countries with warm, wet climate, tropical countries, in some African countries, and in Asian countries. Hepatitis E virus is transmitted elementary through foodborne or waterborne and occurs in epidemic form in developing countries where water or food supplies are sometimes fecally contaminated. It was first documented in samples collected during the New Delhi outbreak of 1955, when about 29,000 cases of icteric hepatitis occurred after sewage contamination of the city's drinking water supply. An epidemic occurred in Kashmir in India in 1978 that resulted in estimated about 1,700 deaths. Pregnant women may have a high mortality rate, about 20%, if fulminant hepatitis develops. So, this form of hepatitis was identified, was found later than other forms of hepatitis, and it's also foodborne like hepatitis A. Hepatitis E virus is a small non-enveloped virus. It has RNA positive chain, and it has such antigen as hepatitis E viral antigen. Epidemiology and pathogenesis of hepatitis E virus. Its contagious period extends from before to after symptoms. Source are sick men. Transmission via fecal-oral route by ingestion of contaminated food and water. It causes only acute disease. Lifelong immunity occurs after disease. Hepatitis E virus infection is especially serious in pregnant women. Its mortality rate about 20%. Transmission through placenta results in death of the fetus, so it may be transmitted through placenta. What about pathogenesis? Pathogenesis of hepatitis E is similar to hepatitis A. Incubation period is longer, from 15 up to 60 days. Clinical illness at presentation consists from 70 up to 80% in adult person, can cause severe acute hepatitis. Subclinical infection is common. Jaundice is common. Fulminant hepatitis occur in less than in 1% in pregnancy, up to 13% of cases. Case fatality rate is less than 1%, but in pregnant women it is increasing. There is no chronic infection. Microbiological diagnosis includes firstly collection of stool and blood, and methods that are used is PCR and serological tests. Prophylaxis and treatment. There is no specific treatment of hepatitis E. Prevention is the most effective approach against the disease. At the population level, transmission of hepatitis E virus and hepatitis E disease can be reduced by maintaining quality standards for public water supplies and establishing proper disposal systems for human feces. In 2011, recombinant subunit vaccine to prevent hepatitis E virus infection was registered in India. It has not yet been approved in other countries. The another virus that we should discuss today is human immunodeficiency virus. It belongs to family Retroviridae and genus Lentivirus. Firstly, some words about its history. In the late 1970s and early 1980s, an unusual number of young homosexual men, Haitians, heroin addicts, and hemophiliacs in the United States were noted to be dying after opportunistic infections. Opportunistic infections, I remind you, infections caused by opportunistic microorganisms of normal microflora. Their symptoms defined a new disease that they acquired immunodeficiency syndrome. Dr. Montagnier and associates in Paris and Gallo and colleagues in the United States reported the isolation of human immunodeficiency virus from patients with lymphadenopathy and acquired immunodeficiency syndrome. A closely related virus designed HIV-2 was isolated later and is prevalent in West Africa. In this map you can see global prevalence of HIV infection. Dark blue color shows countries with a prevalent amount of human immunodeficiency virus. The overwhelming majority of people with HIV virus live in the developing world. Sub-Saharan Africa accounts for 2/3 of all infected people, about 67%. South and Southeast Asia has the second highest number of infected people. If we talk about South Asia and Southeast Asia. What about amount of HIV patients? In India, about 2.1 million people living with HIV. It's about 0.2% of all people living in India. In Egypt, about 13,000 people. Maybe it is bigger now. In Russia, about 1.1 million people. HIV infection in Alliance lasts for 22 years since 200. The total number of HIV infected in Ulyanovsk region today is about 16,555 people. Structure of genome. HIV is a spherical enveloped virus. The genome is composed of two identical single-stranded RNA positive copies. They are here. In association with viral RNA is the reverse transcriptase enzyme. It's the only virus that have a reverse transcriptase enzyme, which is characteristic feature of retrovirus. What is the action of this virus? When the virus infects a cell, the viral RNA is transcribed by the enzyme, first into single-stranded DNA and then to double-stranded DNA. It's provirus, which is integrated into the host cell chromosome. This virus may be cultivated in cell lines of T cells, T helpers. What are antigens of HIV virus? These are glycoprotein 41. It's then glycoprotein 141, this one. Glycoprotein 120 is here. P17 or protein 17 is here. And P24 is here. Glycoprotein 41 and glycoprotein 120 form lollipop-like spikes. You can see lollipop-like spikes. What is action of these glycoproteins? Glycoprotein 120 binds to the CD4 protein on T helper cells and macrophages and is recognizing by neutralizing antibodies. So the main function of glycoprotein 120 is attachment to CD4 cells. Glycoprotein 41 allows fusion of the virus with the cell membrane. It's allow fusion or entry of virus into um, CD4 cells. Glycoprotein 120 and glycoprotein 41 has mutation that occur during the course of a long HIV infection. Within one organism, one patient, these antigens may be changed during the infection. Epidemiology and pathogenesis of HIV infection. Source is sick man, transmission through sexual contact, then blood contact through needle sharing behavior, injection drug use, and other needle sharing, blood and blood products transfusion. The third transmission way is tissue and organ donation, cornea, bone marrow, or kidney, and perinatal transmission from mother to fetus, intrauterine transmission through placenta during birth, or through breastfeeding, because a mother breast milk also contains large amount of HIV virus. So HIV virus enters such human body fluids as blood, lymph, vaginal and excretions, sperm, and breast milk. Who are highest risk patients for HIV? These are sexually active people, homosexual and heterosexual, who have unprotected sexual contact. Intravenous drug abusers and their sexual partners, and newborns of HIV-positive mothers are at higher risk for HIV infections, with Black and Hispanic persons disproportionately represented in the HIV-positive population. Pathogenesis of HIV infection. The primary pathogenic mechanism of HIV infection is a damage in the CD4 T lymphocytes. Also, monocytes and macrophages may be infected. The CD4 cells decrease in number, then CD4 CD8 ratio helper to suppressors is reversed during infection. Infected CD4 cells don't release normal amount of interleukin-2, gamma interferon, and other cytokines. You remember that CD4 cells activate CD8 cells and C and B cells. Acquired immune deficiency syndrome patients are unable to respond to new antigens to other infections. Monocyte macrophage function are also affected. As a result, chemotaxis, antigen presentation, and intracellular killing by these cells are diminished. Monocyte macrophage escape immune surveillance and transfer the infection to other organ systems, particularly the lungs and brain. There are some stages of HIV infections. These are acute retroviral syndrome within from 2 up to 4 weeks of acquiring HIV. Asymptomatic or latent HIV infection, its variable duration, persistent generalized lymphadenopathy, acquired immune deficiency syndrome related complex, and advanced HIV infection or AIDS. The first one is acute or early infection. It's characterized by flu-like or mononucleosis illness. Patient has such clinical symptoms as fever, headache, rash, myalgia, arthralgia, gastrointestinal symptoms, diarrhea, nausea, or vomiting. Neurological symptoms as septic meningitis, encephalitis, lymphadenopathy, or organomegaly, enlargement of internal organs. P24 antigen can be demonstrated at the beginning of this stage. HIV antibodies may be negative, they are not detected. It's so-called a window when antibodies are absent. The second stage is asymptomatic HIV infection, when variable duration of time is present. It's as little as from 1 up to 2 years to more than 15 years. Steady state viral load. It means viral load means replication, massive replication of virus in the bloodstream. The another stage is a persistent generalized lymphadenopathy, when we can see gradual fall in CD4 cell count, enlarged lymph nodes at least 1 cm in diameter that persist for at least 3 months. It is abnormally when patient has so large lymph nodes during this long period. The fourth stage is called acquired immunodeficiency syndrome related complex. It's characterized by generalized lymphadenopathy and splenomegaly, fever, malaise, night sweats, persistent diarrhea, and marked weight loss of more than 10% of body weight. Then herpes zoster, vaginal candidiasis, tuberculosis, and salmonellosis are most frequent infections in such patients because um, uh, weak immune response causes reactivation of herpes virus or candidiasis and tuberculosis if it's present, increasing viral load and decreasing CD4 cell count in the blood. And the final stage of HIV infection is acquired immune deficiency syndrome. This is the end stage disease representing the irreversible breakdown of immune defense mechanism, leaving the patient a prey to progressive opportunistic infection and malignancy. Because immune response to tumor cells is also absent. CD4 cells are not activated. CD8 cells, that is a main mechanism of anti-tumor immunity, are also not activated. The clinical severity of acquired immune deficiency syndrome varies with the type of infection or malignancy present. In early acquired immune deficiency syndrome, many patients are ill only during episodes of infection which may respond to treatment. Between episodes, they may be relatively well and are able to resume normal life. Diagnosis, treatment, and prophylaxis of HIV infection. Specimen is blood, semen, vaginal discharge, breast milk. Methods include the first one, antigen detection by ELISA to detect core antigen P24 in the first few weeks after infection, and in the terminal phase the test is uniformly positive. The second one is virus isolation from the peripheral lymphocytes by co-cultivation of the patient's lymphocytes with uninfected lymphocytes. It's not suitable as a routine diagnostic test. Uninfected lymphocytes then are also infected in the presence of virus. Polymerase chain reaction, the classic standard for diagnosis in all stages of HIV infection, becomes necessary, particularly in the course of treatment. The fourth one is antibody detection. IgM antibodies appear in about from 4 up to 6 weeks to months after infection, to be followed by IgG antibodies. It's detected by ELISA or immunoblotting or Western blot test. What about prophylaxis? All candidates HIV vaccines tested have proved ineffective or poorly effective at prevention infection. Vaccine development is difficult due to HIV mutation. Treatment of HIV. Actually, patients with HIV infection may have normal life, but they must get antiretroviral therapy during all their life. There are some groups of antiretroviral drugs. The first one is nucleoside analog reverse transcriptase inhibitors that inhibit viral polymerase. It is zidovudine and lamivudine. The second one is non-nucleoside reverse transcriptase inhibitors that inhibit viral replication. It's nevirapine. The third one is protease inhibitors that inhibit enzyme preventing infecting other human cells. It is secovinavir or Inverase that first was approved in 1995. And it's also ritonavir. So patients with HIV must take combination of all these drugs. The another group of infectious agents that we should discuss today is prions. Prion is naked protein molecules that are lacked of nucleic acid and cause slow infections. The normal prion protein, which is designed as PRPC, is found on the surface of brain cell neuron. Our normal cells have this protein. It may guide maturation of nerve cells. PRPSC, scrapie-like prion protein, is abnormal protein that causes spongiform degeneration of brain when a brain becomes porous like a sponge. PRPSC have ability to convert normal protein into abnormal protein that are accumulated in neurons. Then, as the neuron die, vacuolar areas form in the gray matter. It causes disruption of gray matter in the brain. Prions are lack of any antigenicity, lack of any inflammation ability, lack of immune response, lack of interferon production. They have long incubation period of several years, unusually resistant to heat up to 80 degree Celsius, and resistant to ultraviolet irradiation and disinfectants. They are transmitted by injection, by transplantation of contaminated tissues like corneas, contact with contaminated medical devices, and elementary through food. For example, firstly, it was detected in members of a tribe in New Guinea. Members, especially women and children of the four tribe in New Guinea, were at risk for Kuru because of ritual cannibalism. Cannibalism when people eat each other. The human prion disease are spongiform encephalopathies that include Creutzfeldt-Jakob disease, Kuru, Gerstmann-Straussler-Schenker disease, and fatal familial insomnia, when patients lose their ability to sleep. They can't sleep. The spongiform encephalopathies are characterized by a loss of muscle control, shivering and tremors, loss of coordination, rapidly progressive dementia, and death. They are also found in animals and include a disease called scrapie in sheep and goats, transmissible mink encephalopathy, and bovine spongiform encephalopathy, mad cow disease. So, prions are not viruses, not bacteria, not microorganisms. These are only proteins that are transmitted through injection or through transplantation of infected tissues or contact with devices where these proteins are served, because they are very resistant to different disinfectants, and they cause disruption of the brain. There are no methods for directly detection of these prions in tissues. Definitive diagnosis requires examination of biopsy, brain or nervous tissue, and this procedure is usually considered too risky. High risk. Electroencephalograms and magnetic resonance imaging can be used. Prevention of either type of spongiform encephalopathies relies on avoiding any contact with infected tissues. No known treatment exists for spongiform encephalopathies, and patients die. And the last group of diseases that we discussed today are oncogenic viruses. Oncogenic viruses are viruses that produce tumors in hosts or induce malignant transformation of cells. Mechanism for oncogenesis. The first one, oncogenic viruses activate growth-stimulating genes. Oncogenes are genes responsible for the induction of tumors. The second one, oncogenic viruses inhibit mechanisms that limit DNA synthesis and cell growth. That's why human cells grow without apoptosis. And another mechanism when oncogenic viruses prevent apoptosis. Apoptosis, it is cellular death. Which viruses are able to cause tumor? Hepatitis B virus, Hepatitis C virus, Epstein-Barr virus, human herpes virus type 8 that cause Kaposi sarcoma, human papilloma virus, and human T-cell lymphotropic virus. High risk human papilloma virus types. Remember, please, it is type 16 and type 18. They can initiate the development of cervical carcinoma in women. These are main causative agents of tumor of cervix. So, students, that's all. Keep calm. Our microbiology lectures are finished. Thanks for your attention during this semester. I hope it will be possible for you to learn this lecture, to understand. Sure, there will be a lot of questions. We will talk, we will discuss them in our practical class. Goodbye, take care of you. This is the last microbiology lecture.